You had an interesting video where you were teaching women about the estrogen cream and
Yes,
how to measure it and not reuse that applicator that it comes with. Can you talk to us more about that?
sure. This is one of the little nuances of just making life easier and more simple. Estrogen vaginal cream is not for systemic estrogen, but to treat or to prevent what we call the genitourinary syndrome of menopause.
Hi, this is the Care Room with Dr. Cindy. Welcome. It's a space that was created just for you. I'm your host, Dr. Cindy, and this is a chance to get up close and personal with me. We're going to talk about the things in medicine that matter to you. We'll talk about the questions you've been carrying. We're going to have some honest conversations. We're going to hold space for joy, struggles, and everything in between. It's care that goes beyond the exam room. Care you're going to take home with you, whether you're listening while you're driving or you're listening while you're exercising. I promise that it's going to be care that's rooted in truth and a deep commitment to walking with you every step of the way. I'm glad you're here.
Well, hello. Hi, everyone. Welcome to another episode of the Care Room with Dr. Cindy. You are in for a treat today, ladies. We have the wonderful Dr. Traci DeSplinter here with us. She's a board certified OBGYN. She is also certified in obesity medicine. She's menopause certified. She is doing it. And she's here today to share her wisdom with us on all things menopause related. So, like I said, we're in for a treat. But before we get started, I am going to let her introduce herself and tell us all about her.
Hi, Dr. Cindy. Thank you so much for having me on. I've been looking forward to chatting with you and being on your show. I am Dr. Traci DeSplinter. I am a board certified OBGYN with 25 years experience in general OBGYN. More recently, I have become menopause certified through the Menopause Society, and I am also board certified in obesity medicine. I run a direct care practice in Houston for women where we meet all the needs in a comprehensive way of midlife women. So perimenopause, menopause, and the things that come along with these years in our lives, which are changes in our hormonal health and our metabolic health. Try to meet the needs of midlife women in every way that I can.
Absolutely. And thank you for doing what you do. Because for so long, right, Dr. Tracy, it has been, I wouldn't say it was neglected, but, it was one of the things that, yeah, we weren't taught about in med school as much. It was almost something that women just had to go through and kind of endure it. So can you tell us, for a lot of women, we'll start at, very basic and then kind of work our way up. Can you tell us what menopause is?
Yes, menopause is the cessation of periods. It happens on average around age 51 or 52, although it can be several years sooner or later. And it happens when the supply of eggs in the ovaries is exhausted. So we are born with all the eggs we're going to have. In fact, they start disintegrating and being lost even before we're born. So when we are a fetus inside our mom's uterus, we have the most eggs we're going to have around 4 to 5 months of gestation. And then we start losing them. And every month, an egg is ovulated after puberty and before menopause. But even before puberty and all through the reproductive years, a group of eggs is lost every month. So once those are gone, we hit menopause.
Yeah. Yeah, fun times, huh?
It,
So can you tell us what menopause looks like for a woman?
it looks different for every woman, actually, Dr. Cindy. So this care has to be really nuanced and personalized. 7 to 10 years before menopause, women start to experience perimenopause. And some of the changes in perimenopause, especially early on, are often not recognized as being part of perimenopause. Some inflammation in joints and soft tissues, plantar fasciitis, tendonitis in the thumb or the elbow. Different joint issues can arise, sleep interruptions and poor sleep, a sense of fatigue. These things happen often even before any changes in the menstrual cycle and before any hot flashes or night sweats. So that's kind of how it starts.
Yeah.
Some women have really debilitating symptoms and some have none. Then as the perimenopause progresses, there can be some changes in periods. They can either be further apart or sometimes they actually get closer together. They should never be any closer together than 21 days from the start of one period to the start of the next. That's a red flag if they're closer than that. But just some changes in the frequency and flow of the periods can happen. Hot flashes, night sweats,
Yeah.
insomnia,
Yeah.
musculoskeletal issues, changes in sex drive, just changes in overall well-being and a sense of just not feeling well, just not feeling like yourself. Irritability is a common complaint during this time. And then eventually the periods start to become fewer and fewer each year until you go a whole year without a period. And that's the definition of menopause.
Right. Right. And as you guys, as you've heard, it's not fun. It doesn't sound fun. Women become irritable, and we always, we have this kind of bad association. Like, whenever a woman is in a bad mood, it has to do with her hormones. Not nice, but there is some, I guess, some medical basis to it, though we can't always lean on it. But can you tell us what we can do about those symptoms if we do have them?
Definitely. Symptoms are absolutely treatable, and you don't have to just, quote, power through. You don't have to power through. There's no trophy for doing that. It may have some adverse consequences on your health, especially years of sleep deprivation is just not a healthy way to survive. So powering
Oh,
through.
you mean powering through? Powering through can have the adverse
It can. I
effects.
mean, if one of your main symptoms is loss of sleep or loss of good quality sleep, then that's just one example of how powering through could have an adverse health consequence. So you need to find a physician who understands perimenopause and menopause and doesn't just say to you in mid to late 30s, oh, you're too young, it couldn't be that, or oh, you're still having periods, it couldn't be perimenopause. It absolutely can. Now, it is important to check for other causes of your symptoms. We don't want to get tunnel vision and focus solely on perimenopause because there are other common issues that can cause some of the same symptoms. For example, thyroid disease is super common in women in this age group, and it's very important to have those other potential causes of symptoms evaluated.
Absolutely. Absolutely. So I know there has been a lot of talk, a lot of the work that you guys are doing. Can you tell us about the new things happening in the world of menopause and perimenopause?
I think there's just a big awakening, like a new recognition by the lay public and by patients, um, often through social media, which, is a double-edged sword. It's good and bad, but it has been effective in getting the word out to patients that this is something that it can be safely treated and that they don't have to be miserable for, 10, 15 years or even longer.
Yeah. Yeah. So what would treatment look like?
It kind of depends on the symptoms. It should look very individualized. It should look like a relationship with your doctor who really has time and takes the time to listen to what you're experiencing, evaluate for other causes, like I mentioned, and then tailor the treatment specifically to you and your symptoms. It's not a one size fits all. So sometimes it's hormonal treatments like menopause hormone therapy. Sometimes in early perimenopause, that doesn't help and even makes people feel a little bit worse. It's very individualized. Sometimes it could be a low dose birth control pill if the patient is open to that. And perimenopause, sometimes that works better. It just really has to be personalized and tailored directly for you.
Got it. Got it. Dr. Tracy, you're in the unique position of being board certified in menopause and obesity. Can you talk to us about the link between those?
Yes. So there's an important link there. There is an association just between aging and weight gain for both men and women. Menopause, as we pass through perimenopause and into menopause, there is some weight gain that occurs, but also there is a shift due to the change in hormones from the ovaries. There's a shift in where we carry our weight that's very important for metabolic health. So even if you don't gain weight during perimenopause or strictly due to perimenopause, for most women, there is a shift from the weight being carried on the hips and thighs right under the skin to around the abdominal area. And some of that is under the skin in the abdominal area, but some of it is what we call visceral fat, which is fat that accumulates around the organs of the abdomen and even around the heart. And visceral fat is really important to pay attention to and to minimize because it has metabolic effects that adversely affect our health. So it produces a lot of inflammatory cell mediators that increase inflammation throughout our bodies. And this increase in inflammation and visceral fat, along with weight gain, along with sleep consequences and different things that are happening with hormones, can cause an increase in insulin resistance. It can increase the risk of cardiovascular disease, has some really intense negative consequences, can change the cholesterol panel for the worse, can lead us toward prediabetes and diabetes, which has lots of health consequences. So that's one of the big connections between menopause and weight gain or shift of weight to the midsection.
Yeah. So would treating patients with obesity in the perimenopause and menopause period be different from younger patients?
Yes, I think so, because there's a complex interplay between the loss of ovarian hormones and then the hormones that the gut is making that change appetite, and then the deposition of fat in different areas, like viscerally, like I was talking about. Actually, women in perimenopause and menopause who are being treated for obesity, they lose more weight on the GLP-1s if they are also receiving menopause hormone therapy. So menopause hormone therapy in and of itself is not a weight loss medication and usually doesn't alone result in weight loss, but it can enhance the effect of the really powerful weight loss medications that we have available to us now.
Absolutely, absolutely. Can you explain to us and those, well, us ladies, what the big hoopla was about estrogen and not taking it via pills or patches, and there was that black box warning.
Yes.
Yeah.
So in the early 2000s, 2002, I believe, I trained before this big study was announced. So I learned about hormone replacement therapy is what we called it at the time before the hoopla. And in the 90s and around the year 2000, most women it was menopause hormone therapy was accessible to most women in perimenopause and menopause if they wanted it. Then in 2002, there was a study, and before it was even published, there was a press conference to announce the results of a study. This is a very unusual. Typically, when medical studies are released that are published that affect medical care, they are published in peer-reviewed journals. They're reviewed. They're interpreted by the medical community, and the word kind of gradually seeps out. But instead of allowing the publication, they had a press conference. And the press conference announced in a very alarming way the results of the study, which were now looking back in hindsight, we think it was a bit of a misinterpretation or overinflation of the risk. But it implied that hormone replacement therapy increased the risk of breast cancer, of heart disease, and they even said probable dementia. So a whole generation of women who are just older than I am lost their hormone therapy immediately, and those who came into menopause in that next 20 years didn't have the option for hormone replacement therapy or menopause hormone therapy. Since then, the study has been re-examined and other studies have been done, and the thought on it has really changed. So just late in 2025, the black box warning on hormone replacement therapy products was removed. Thank goodness. Yes. And the availability of menopause hormone therapy is back. Still, most women are not offered menopause hormone therapy, but I think the word is getting out that this can be done very safely for the vast majority of women.
Absolutely. Absolutely. So can you help us dig into that more? Is the patch better or is it worse versus, the pill, the estrogen pill, or the topical cream? Can you
Yes.
talk about the different formulations?
Sure. There is a benefit for women who can tolerate what we call transdermal estrogen replacement. This would be a patch or a gel, for example, or even there is a vaginal ring that provides systemic estrogen replacement. The benefit to the transdermal as opposed to the oral is that the transdermal estrogen does not increase the risk of blood clot formation. This is abnormal blood clots like in your legs or your lungs. Oral estrogen is still an option, but it does have to go through the liver before your body can benefit from it. So you metabolize part of it before you can actually notice a benefit from it. And that liver metabolism also stimulates some proteins in the liver that can increase very slightly, but still a slight increase in the risk of abnormal blood clot formation. So some women don't tolerate the transdermal methods very well because they have an allergy to adhesive, for example, so the patch doesn't work for them. The gel is still an option, but for whatever reason, some women don't like or don't respond well to the gel. So oral estrogen is still a valid option, but in general, it's better to try for transdermal estrogen replacement first. There's also a spray. The spray seems to not have very good insurance coverage. There
Okay.
is a spray. So there's several transdermal options, and those are better to try, in my opinion. Those are better to try first. And then if for some reason women don't tolerate those, oral estrogen is still an option and is still very safe for the vast majority of women.
Okay. Got it. Got it. So, guys, Dr. Tracy is on social media. At the end, she'll give us, all the deets, all the details as to where we can find her. But you had an interesting video where you were teaching women about the estrogen cream and
Yes.
how to measure it and not use, like, reuse that applicator that it comes with. Can you talk to us more about that?
Sure. This is one of the little nuances of just making life easier and more simple. Estrogen vaginal cream is not for systemic estrogen, as we were talking about before, but to treat or to prevent what we call the genitourinary syndrome of menopause. And this is where the vaginal tissue becomes thin, tender. It loses its ability to expand. Sex can become painful. The risk of urinary tract infections goes up. And for elderly women, urinary tract infections can actually become life-threatening very quickly. And there are some
Absolutely.
anatomic changes that happen when the vaginal and bladder and urethral and clitoral tissues and the vulva are deprived of estrogen for years, ameliorated by using topical vaginal estrogen, which is very, very safe. Even women who have contraindications for systemic estrogen can very safely use vaginal estrogen. So vaginal estrogen, the estradiol cream, it comes as a generic. It's not expensive. But one frustration that a lot of patients have expressed to me is that the tube lasts several months and it comes with only one vaginal applicator. So the dose is typically 0.5 gram or 1 gram a couple times a week. And you're left washing and rewashing that applicator over and over and over multiple times for the several months that the tube lasts. So there is an option to order more vaginal applicators on Amazon, or you can buy those commercially or buy those through retail. But that's another bit of an expense and just a hassle. The other way around it, the other thing about the applicator is when the vaginal tissue is very thin and tender, the applicator may not be super comfortable. It can be kind of uncomfortable to insert. So one suggestion that I have is when you first get the estrogen cream prescription, pull up the dose in the applicator the first time, and then put that cream on your index finger and eyeball it. Then you can see this is 1 gram or this is 0.5 gram. It doesn't have to be exact. Once you know what 1 gram looks like, if that's your dose, then the next time, when you're doing this twice a week, the next time you're ready for your dose, instead of using the applicator, just toss it and put that 1 gram amount on your finger. Then it can be applied in a more comfortable way without having to wash the applicator. And it has the added benefit of what's left on your finger after the vaginal application can be placed on the vulva, on the labia minora, the clitoris, the urethral opening where the urine comes out, because those tissues are estrogen sensitive as well.
Yeah. They're dry. They need food. They need, that's amazing. Simple.
Yeah, simple.
Like,
Yeah.
yeah, and I'm glad that you're educating. I'm glad that you're out there, spreading the word because it's definitely, definitely needed. So, can you tell them where they can find you, Dr. Tracy?
Yes, I'm in the Houston area. My practice is called Refined Women's Health. Website is refinedwomenshealth.com. I am on Facebook and Instagram with using my real name, Traci DeSplinter, MD, on both of those platforms.
Yes, go check it out, guys, and look for that video. I was so impressed when I saw it. Make it go viral because all the
I'm
ladies, we
glad
need
you,
to know.
yeah, I'm glad you enjoyed that. It's a simple thing.
I did. But yeah, thank you so much, Dr. Tracy. Thanks for your wisdom. Thanks for your expertise. Thanks for your advocating for women everywhere. I know, it can be difficult at times to move the needle, even just a little.
Yes.
But you guys are doing it, and we thank you guys. Salute you. So this one. Yes. So guys, I will have another awesome, amazing guest on with me again next week. But until then, please enjoy this podcast with Dr. Tracy. Check out her website, and we will see you again next week. So take care. Bye.
Thanks for spending time in the care room today with Dr. Cindy. If you liked what you heard, please subscribe, share this podcast. I'm also on Facebook and Instagram. You can follow me there. Remember, you're not alone in this. There are doctors who do care. The information in this podcast is for educational and informational purposes only. It is not a substitute for professional medical advice, treatment, or diagnosis. Always consult your personalized healthcare provider for medical guidance.